Hi, this is Dave Johnson from iPro. I am a Senior Quality Improvement Specialist and have been with iPro since 2002. I'm an administrator by background since 1976, and I have also been certified in the MDS 3.0. I'm going to talk today about a quality measure case study. In particular, I will speak to the high-risk pressure ulcer quality measure and the detail as to what exactly is used from the MDS to calculate that quality measure. I will be speaking about how to understand the individual quality measure as it ties to the QM specifications and the RAI manual. My goal is to provide you with a process illustration on how to investigate any quality measure that is calculated from your facility's MDS submissions. The iPro QIN-QIO is a federally funded Medicare Quality Improvement Network quality improvement organization who, in combination with our partners, including Health-Centric Advisors and Clarent, provide quality improvement support and guidance across 11 states and the District of Columbia. For a quick snapshot, we offer both enhanced resources and support to healthcare providers as well as the patients and residents they serve. We support family engagement in all settings and provide information and resources in support of evidence-based innovation and data-driven methodologies. Though we are funded by Medicare, our role is non-regulatory. If you think about it in terms of the nursing home environment specific to things like the quality measures, you are already self-reporting your data through your MDS submission process. Specific to the nursing home sector, our current quality initiative efforts circle around the best practices and person-centered approaches to decrease opioid prescribing, reduce adverse drug events, the reduction of healthcare-acquired infections, the minimization of both ED visits and readmissions, and the improvement in the mean total quality score. My primary goals for this presentation are to provide you with a process model to investigate any quality measure that is derived from your MDS submissions, and to recommend a step-by-step process to investigate and analyze your facility's MDS QM data. Now, just for quick review, within the 5 elements of QAPI, Element 3 speaks to feedback, data systems, and monitoring. The key points within this element talk about having a system in place to monitor care and services. Once collected, you need to organize that data in a way that is understandable to your team. It mentions an effective use of clear data that is factual and not based on assumptions, and making sure that factual data is readily available to ensure that your performance improvement project teams are targeting the right areas and have the ability to monitor that progress. The resources I have used for this presentation are listed on this slide, and I'll speak to them individually. The MDS 3.0 Quality Measure User's Manual, right now version 15. The manual explains all of the details for the calculation of each quality measure. I will also be referencing the MDS 3.0 RAI Manual, the latest version being some 1,300 pages. And the CMS QAPI Guide, What You Need to Know. That's a companion guide from CMS's QAPI at a Glance. All of these resources are available on the internet by simply searching by the document name. They are all in PDF format and may be downloaded and printed for easy and quick reference. I just mentioned about the MDS RAI Manual being over 1,300 pages, but I want to drill that down a little more. On this slide, you will see the link that takes you to the entire manual. However, specific to this presentation, my focus goes specifically to Chapter 3 of that manual, the chapter that provides item-by-item guidance to the MDS 3.0. This portion of the manual is very easy to navigate, extracts specific pages related to focused items on the MDS, and you can easily print individual pages for your team's quick reference to assist them in their focused efforts related to an individual quality measure. On that same website, I grabbed a screen print from the left-hand side of the web page that you will see offers additional links to the important information you are involved with during your day-to-day operations. Specifically on this slide, this is where you can easily find the link to the latest quality measure user's manual, one of the other resources tapped in this presentation. A couple of helpful hints: you may also note that other links related to things such as Care Compare, value-based purchasing, and the SNF quality reporting program are also on this slide. Something else that may help you with your full understanding of how this all ties together: when you go to the quality measures link, at the bottom of the page is the link to the 5-star quality rating system page that offers an enormous amount of information and downloads. Again, my source for this information is the actual MDS 3.0 Quality Measures User's Manual that is available on the internet. For each of the quality measure specifications, there are 3 components or 3 sections. The measure description, which is a short description of the quality measure itself. The measure specifications, which details which residents are in the numerator and in the denominator, as well as any exclusions for that specific quality measure. And finally, covariates, which relates to any risk adjustments being made in the quality measure calculations. This next slide is an actual example of the quality measure specifications, in particular the long stay measure related to high-risk residents and pressure ulcers. By using this resource, you can clearly see what item or items on the MDS places the resident in the numerator, again also known as triggers, as well as what MDS coding responses will exclude them from the calculation. The specification explanations are very detailed to the individual MDS items that impact this quality measure. You may also note that I circled something at the bottom of the page. This is where the current QM manual indicates if a particular quality measure is used in the 5-star quality rating system. You can easily see by this example that the long stay measure for high-risk pressure ulcers is in fact used in the 5-star rating system. This slide identifies the covariates section of the table. As mentioned previously, there is only a subset of measures that are risk adjusted. Those include short stay measure for residents who made improvement in function, the long stay catheter left-in bladder quality measure, and the long stay quality measure for those residents whose ability to move independently had worsened. In this example for the high-risk pressure ulcer quality measure, there are no covariates, so there is no risk adjustment. If applicable to the individual quality measure, the covariates are detailed down to the individual MDS item coding. The quality measure specifications offer item-specific detail tied directly back to identified entries on the MDS. If you investigate the actual coding guidance available in the RAI Manual, that drill-down process will provide direction in the coding requirements, along with the necessary guidance and expectations to impact your specifically targeted quality measures. It is really a loop to make sure that the facility's knowledge base is in alignment with the interpretation provided and the guidance offered in the RAI Manual, and that you have systems in place to capture appropriate information to support your MDS coding. Now you may ask yourself, why am I telling you all this? And simply put, it goes back to the math. For example, the measure related to your long-stay high-risk residents who have a pressure ulcer. The numerator is simply your long-stay residents with a stage 2, 3, 4, or unstageable pressure ulcer during the look-back period. The denominator is simply all of your long-stay residents who have been identified by the MDS as being at high risk for the development of pressure ulcers. Change either of those pieces of the formula and you change the result. For the purposes of this presentation, I'm going to stick with the high-risk pressure ulcer quality measure and the discussion of pressure ulcer risk. The common definition can be defined along the lines of accepted standards of practice to include current research and the use of a validated tool, an example of which is the Braden scale. Now I will talk about the MDS definition for the calculation of risk for the development of a pressure ulcer. Even though there is a question, specifically M0100, on the MDS related to the facility's determination of risk, asking about the use of any formal assessment instrument or tool, and then a follow-up question as to whether the resident was found to be at risk, specifically M0150. Simply put, the answers to those two questions don't really go anywhere. For purposes of the MDS, there are three items that the MDS uses to determine pressure ulcer risk. Item B0100, comatose. If that item is coded 1, then the resident is at risk for the development of pressure ulcers, and that makes sense. Another item is in section I, item I5600, malnutrition or the risk of malnutrition. If that item is checked, that resident is at risk for the development of a pressure ulcer. Again, it makes sense since the proper nutrition is necessary for the maintenance of the largest organ of the body, that being the skin. And the third item that will identify a resident as being at risk for the development of pressure ulcers is what the measure looks for in a resident who has impairment in either bed mobility or transfer. Now let's talk about that for a couple of minutes. This is a screen print of the section of the MDS, specifically section G, functional status, that the MDS looks to for any impairment in either bed mobility or transfer, specifically the self-performance coding as circled on this slide. The MDS looks for any code of 3 or higher, 3 being extensive assistance, 4 is total dependence, 7 is activity occurred only once or twice, and 8, the activity did not occur. And again, it is looking at self-performance, not support or number of staff assisting. That has nothing to do with pressure ulcer risk. The bottom line is that the MDS calculation of risk is largely dependent on the accurate capture of your ADL self-performance coding. Now here is a screen print directly from the RAI Manual specific to the coding of extensive assistance versus limited assistance. Remember that the high-risk pressure ulcer quality measure is looking at any code of 3 or higher in the self-performance area, specific to either bed mobility or transfer, as a risk factor in the development of pressure ulcers. You will see that I've circled the RAI guidance for both limited and extensive assistance. This is where I believe things really get confusing, specifically the MDS definition of limited and extensive, extensive involving weight-bearing support, and limited involving non-weight-bearing support or guided maneuvering. The topic of full understanding and accurate capture of ADL self-performance codes is truly an educational session by itself, but I touch on it here to illustrate the importance of drilling down and understanding what each QM is looking for on the MDS, and how the RAI Manual provides guidance in the coding of those items and how it impacts the individual quality measure. You will also note that this screen speaks to the rule of 3. Again, remember that the look-back period is 7 days, 24 hours a day. And remember that we are looking at episodes, not shifts. That is a common issue with facilities that have their method of capture for the ADL self-performance structured to shift as opposed to captured by episode. Simple example of this could be a resident who needs to go to the bathroom. In this case, they are sitting in a stationary chair in their room and they need weight-bearing assistance to get to a standing position to ambulate to the bathroom. That counts as one episode. When the resident is brought back to the stationary chair, they need weight-bearing assistance to be eased back into the chair. That is another episode. In this case, you only need 3 or more episodes to be coded as extensive assistance in transfer. And again, the look-back period is 7 days, 24 hours a day. Now let's go back to the actual MDS form and the definitions offered for both bed mobility and transfer. Bed mobility: how the resident moves to and from the lying position, turns side to side, and positions body while in bed or alternate sleep furniture. Transfer: defined as how resident moves between surfaces including to and from the bed, chair, wheelchair, standing position. Note that transfer on this item in the MDS excludes to and from the bath or toilet because that information is collected elsewhere on the MDS. Now I ask you just to sit back and think of instances, or more appropriately, episodes of either bed mobility or transfer. For bed mobility, sitting a resident up in bed in preparation for getting up. Moving a resident's legs either from the bed to the floor or laying the resident down for a rest. Lifting the resident up to adjust their pillow. Turning them in bed during wound rounds. And the examples go on and on. For transfer, helping a resident with weight-bearing assistance stand up or sit down in a chair or wheelchair. In this case, I ask you a simple question. Does your facility use gait belts? Are there any times that those gait belts are being used to provide weight-bearing assistance to either stand up or sit down? If those instances or episodes are not being captured as extensive assistance, then the gait belts must be just some form of a fashion statement. Now again, just for illustration, here's a screen print directly from the RAI Manual with coding instructions for ADLs. The instructions are detailed and they speak to the 7-day look-back period, again being 7 days, 24 hours a day. They also speak to variations from day to day or shift to shift, and the importance of a 24-hour picture of what the resident actually does for himself or herself. Think about your residents who you may see during every day, up and dressed, walking around your facility, socializing, and then think about how they may be at 2 o'clock in the morning when they need assistance to get out of bed to go to the bathroom. Remember, 24 hours a day for the entire 7-day look-back period. Look again at the slide. It speaks to mood and medical condition at the time, and the resident's willingness to do things for particular nursing assistance. Say, for example, that a CNA is assisting a resident to get up from a nap and they lift a resident's legs from the bed to the floor. in preparation for standing up. If they were to ask the CNA if they consider that to be extensive, they would probably say no. But according to the MDS, that is extensive assistance because it is weight-bearing. And again, the topic of what I call the MDS as a second language is an educational session in itself. It is important for everyone on the care team to understand what the MDS is asking for and what the MDS definitions are. While it might not make sense compared to your own definitions of extensive and limited, I often say that the MDS is a stupid tool, and if you try to inject common sense reason into a stupid tool, then you're going to miscode. Again, some more coding tips taken directly from the RAI Manual. You will see the guidance to not record the staff's assessment of the resident's potential capability, and do not record what the resident should be receiving according to their written care plan. Record what actually happened. This slide shows two examples from the RAI Manual related to ADL coding. Both coded extensive assistance. One with the assistance of 2 staff, the other with 1. Again, extensive assistance involves weight-bearing assistance, and the self-performance coding has nothing to do with how many staff assist. Weight-bearing assistance is the only variable determining extensive assistance. Now I'm going to use an example of a facility level quality measure report that's available through the CASPER system. Now I take into account the QM specifications, and I know that there are no exclusions in the physical restraint quality measure, and I know that it's a long stay quality measure. So I know by looking at the denominator for physical restraints that there were 44 long stay MDSs in the system at the time of this report. So the long stay population at the time of this report was 44. I also know by looking at the same report that the denominator for high-risk pressure ulcers is 14. That 14 represents the long stay population found to be at risk by the MDS for the development of pressure ulcers. That calculates to only 31.8% of the total long stay population at the time. So the math with 44 long stay MDSs in the system, 1 resident with a stage 2, 3, 4, or unstageable pressure ulcer out of the 14 found to be at risk equates to a quality measure calculation of 7.1%. And you see that on this report. Again, only 31.8% of the long stay residents were found by the MDS coding to be at risk for the development of pressure ulcers. And you have to ask yourself, what about the other 30 long stay residents? Now, simply for illustration, take a look at the revised example of the same 44 long stay MDSs with the same 1 resident with a stage 2, 3, 4, or unstageable pressure ulcer. But now, because of a focused effort to accurately capture and honestly code the ADL self-performance coding for bed mobility and transfer, the denominator is now 40 residents found to be at risk. That calculates to a 2.5% high-risk pressure ulcer quality measure with 91% of the long stay population captured as high risk. Compare that to the publicly reported quality measure of 7.1%. Where should you start? When you get back to your facility, pull your facility level quality measure report. In this case, it really does not matter what the date range you use, whether you accept the default date range or insert your own date range. You're basically just checking the high-risk pulse of your facility. You can even look at an old facility level report that you may have on hand. That might help you to recognize a trend in your statistics. Now, on this report that you're looking at, look for the relationship. Specifically, focus on the denominators for both the high-risk pressure ulcer quality measure and the physical restraint quality measure. It should be easy because they're right on top of each other in the current report. And look for the relationship of those two numbers since they both represent your long-stay population at the time of the report. Remember, the physical restraint quality measure denominator represents the total number of long-stay residents in your facility at the time of the report. And the high-risk pressure ulcer denominator represents the number of those long-stay residents who were determined, again by the MDS, to be at high risk for the development of a pressure ulcer. Now do the math. Divide the high-risk pressure ulcer quality measure by the physical restraint quality measure denominator. That will give you the percent of your long-stay residents found to be, again by the MDS, to be at high risk for the development of a pressure ulcer. In my opinion, the difference between those two numbers equates to those long-stay residents who basically didn't need to be touched by your staff when it comes to either bed mobility or transfer. And again, you have to ask yourself if the statistics from your own MDS coding is a true representation of your population. The biggest takeaway from this: if you are not accurately and honestly capturing your self-performance codes, in this case for bed mobility and transfer, you are potentially understating the number of residents who would be, by the MDS, categorized as high risk for the development of pressure ulcers. Remember, it's a math thing. If you understate the denominator in an equation, you will increase the result. In this case, if you understate your ADL self-performance coding, you will inflate your high-risk pressure ulcer quality measure. Remember what I said about not chasing bad numbers. Whether it's this quality measure or any other measure on the report, pay attention to both sides of the equation. Think process. All of this was just an example of the impact of understanding what a specific quality measure is looking at, the individual MDS items, understanding how the RAI manual is guiding the accurate coding of those MDS items, and developing an internal system of competence to make sure that the quality measures that are publicly reported are an accurate reflection of your facility's population. I talk about building a foundation of accurate data. I just don't want you to waste your time chasing bad numbers. Think about it. If you were pulling your real-time data and saw a 2.5% high-risk pressure ulcer number instead of a 7.1% pressure ulcer number, might your QI focus have been directed elsewhere? The triggers come next. Once you can verify that the data accurately reflects your population, you investigate the triggers in the same manner, tying the quality measure specifics to the individual MDS items and following the guidance offered by the MDS RAI Manual. One more piece of advice. While I focus my example on the self-performance coding of the ADL specific to pressure ulcer risk and that QM, that same section on the MDS is currently in the calculation for two other quality measures, those being the long-stay measure for increased ADL help and the short-stay measure for improvement in function. Something to think about: an issue that I've noticed across all of my time analyzing and evaluating quality measures. Oftentimes, it's a common thing to see an understatement of the high-risk pressure ulcer QM denominator. And then when I look at the bottom of the same one-page report, I see a high worsening in ADL's QM. Are residents actually worsening in their ADLs at that rate? Or is it because of a misunderstanding of the self-performance coding, residents are actually triggering because of what I will call yo-yo coding? Think about it. The specifications for the worsening ADL measure talk about worsening in one late loss ADL by 2 levels, or worsening in 2 late loss ADLs by 1 level. If you have inaccurate self-performance coding bouncing between how staff self-define the difference between extensive and limited, the change from one MDS to the other with varying translation from different staff could cause a worsening when in fact that is not true. If you can make sure that your staff at all levels understand the MDS language specific to the difference between extensive and limited, you may actually be impacting 3 quality measures with that effort, not just 1. To take it a few steps further, ensure that key team members are educated on the Casper data system to tie together all sources and any calculations. Based on a review of your current Casper data, determine areas of focus for analysis and monitoring. When appropriate, charter individual performance improvement project teams to set out to further investigate, analyze, recommend, trial, and evaluate results, with opportunities to spread successes or respond to lessons learned. I know that I've presented a lot of information regarding this specific quality measure case study. I leave you with this slide that contains the contact information for everyone currently on the iPro nursing home team. All of us are well versed in the quality measures since we have been actively using Casper data as our data source to monitor our own progress during our quality initiatives and to assist facilities who reach out to us. If you have any questions about the content of this presentation, please feel free to reach out to me directly. I thank you for your time and have a great day.